And today we have quite an interesting topic lined up. So today we'll be discussing endocrinology complications in patients with pediatric neurological disorders. And joining us today is Dr. Madhura Joshi. She's a pediatric endocrinologist who's practicing in Nairobi, Kenya. And she also has a subspecialty in bone metabolism from Birmingham, United Kingdom. My name is Dr. Lucia Amolo. I'm a child neurologist at KNH, and I'll be your moderator for today. So the topic for today is quite interesting. Many a times we are faced with pediatric patients with neurological disorders, and they may have endocrine comorbidities that arise from the disease itself or from the treatment itself. And some of these diseases are quite many. They can be metabolic disorders like X-linked adrenoleukodystrophy, neuromuscular disorders such as Duchenne muscular dystrophy, tumors such as craniopharyngiomas, infections and trauma. Chronic conditions also cause immobility in pediatric neurology patients, which will result in complications such as obesity. And even the drugs themselves that we use to treat pediatric neurological complications can result in endocrine comorbidities, such as steroids, which cause obesity and suppression of the pituitary hypothalamic axis, as well as medications such as valproate, which are used to treat epilepsy and can cause increased appetite that results in obesity. So Dr. Madhura Joshi will take us through this very interesting topic. Welcome, Dr. Joshi.
Thank you, Lucia, for the kind introduction and so aptly setting the stage for the topic for today. Let me start screen sharing. I hope I'm audible.
Yes, you're very audible.
Okay. Yeah, I'm just trying to share my screen now. 1 second. I hope my screen is seen.
No, we can't. Okay, it's coming. Yes, we can see your screen. Yes, you can just put it on presenter mode.
Right. Yeah, second. Yes. So with your permission, I'll start now.
Yes, you're welcome, Dr. Joshi.
Yeah. Okay, thank you. So like Dr. Lucia just said, it is a very vast topic and an interesting one. And my aim for today will be for all of us to be aware of which endocrine complications can be faced while managing a child who has a neurological disorder, how to recognize them early, how to screen for them, when to refer these children to an endocrinologist, and how to manage these disorders. So without much ado, let me start. So as we all know, pediatric neurological disorders contribute significantly to the global disease burden due to majorly the long-term disability associated with them. A large cohort of such children are present in Asia and sub-Saharan Africa. The causes of neurological disorders, as we just saw, could be varied, ranging from trauma to CNS infections, to metabolic, to epileptiform disorders, to tumors, and so many others. Recent studies from 2015 indicate that in the last 25 years, there has been a reduction in mortality in the early age group, and there has been an increase in the disability-affected life years, especially in older boys and girls of 5 to 14 years age group. This clearly indicates a need for more support and specialized multidisciplinary care to address the evolving issues of this dynamic phase of childhood and adolescence, wherein growth, puberty, and bone health is crucial. Yeah. So how is the endocrine system affected in various neurological disorders? Many neurological diseases have an underlying endocrine affection, either at the beginning or the start of diagnosis, or they present later on. Awareness and anticipation of these endocrine complications allows for proactive screening and early diagnosis, timely treatment of which can result in better prognosis and reduce distress for the child as well as the caregivers. Let me exemplify this. As Dr. Lucia mentioned, children with DMD, due to the underlying disease itself, due to the associated immobility, and the steroid exposure for a considerable amount of time have poor bone health and are known to have decreased bone mineral density and a propensity to long bone as well as vertebral fractures. Screening these children with DEXA scan and vertebral fracture assessment is now the norm, and IV bisphosphonate therapy is the first line for treating the osteoporosis in these children. It has shown reduction in fractures, rates, and improvement in bone health. Similarly, various other neurological disorders affect hypothalamo-pituitary axis, puberty, thyroid function, adrenal gland function, and can result in obesity. There are many drugs such as anticonvulsants, which are especially the ones which induce the cytochrome P450 enzyme and result in a lot of derangements in the thyroid function axis as well as vitamin D metabolism, and hence cause endocrine dysfunction. So we'll go in a bit of detail and look at this one by one. Coming to the hypothalamo-pituitary axis, we know that the brain houses a vital structure known as the hypothalamus, and its tight coordination with the pituitary gland, which we know as the master gland, which secretes most of the trophic hormones and regulates various important life processes such as growth, puberty, reproduction, in addition to salt-water balance and stress response. Is important. So in neurological disorders, which could be either developmental or acquired, they can have an underlying hypothalamo-pituitary axis dysfunction leading to endocrine dysfunction. On the left-hand side, I have tried to enumerate them. So they can range from birth trauma to perinatal insult or hypoxia, which could result in cerebral palsy, or cranial developmental abnormalities such as anencephaly, pituitary hypoplasia or aplasia, septo-optic dysplasias, etc. There could also be infections such as bacterial, fungal, tuberculosis, etc., or infiltrative disorders such as histiocytosis X, thalassemia major, traumas, tumors of the central nervous system, and various genetic and syndromic causes can affect the hypothalamo-pituitary axis and cause hypopituitarism in that scenario. So we know that the pituitary has the anterior pituitary and the posterior pituitary. In the anterior pituitary, we are aware that there are 6 cell lines, of which majority is comprised of somatotrophs or the growth hormone secreting cells. Hence, in any hypothalamo-pituitary axis affection by any of those enlisted causes, what is first seen is growth hormone deficiency. In addition, there could also be underlying other hormonal deficiencies, particularly FSH-LH gonadotrophins, or corticotrophins or TSH, resulting in what we call as multiple pituitary hormone deficiencies. So as I said, the most common one is growth hormone deficiency, and we should be aware of the what clinical features we must look in a child when faced with this particular scenario. So the most important clinical indicator is growth retardation, which can be very easily identified by serial plots of height on the growth chart, and the decreased growth velocity is very evident. We will also see this with the help of a case scenario. So in these children with growth hormone deficiency or multiple pituitary hormone deficiency, growth retardation is a very prominent feature. Weight, on the contrary, is fairly preserved, and these children are short and plump. However, if there is cortisol deficiency, in addition, it may result in a child with a low weight as well. Children who present early with growth hormone deficiency, such as those which have genetic causes or congenital developmental anomalies around the hypothalamo-pituitary region, have typical clinical features of growth hormone deficiency, such as immature faces, small hands and feet, depressed nasal bridge, and underdeveloped mandible. A high-pitched voice is also present in these children. Small genitalia is also a clinical feature that can point towards either growth hormone or multiple pituitary hormone deficiency. On radiological evaluation, another important indicator is a delayed bone age, suggesting underlying endocrine issue. A thorough clinical examination of these cases is very important as it can give us a clue to hypopituitarism and even certain specific syndromes as well. For example, presence of midline defects such as cleft lip, cleft palate, or a single central incisor often prompts to underlying growth hormone deficiency. Septo-optic dysplasia is another syndrome which has a typical clinical feature of nystagmus along with impaired vision. Imaging shows agenesis of septum pellucidum or corpus callosum in these cases, and 1/3 of these children have hypothalamo-pituitary axis dysfunction with deficiency of growth hormone, TSH, and or ACTH. In neonates, if there is a presence of neonatal hypoglycemia along with prolonged conjugated hyperbilirubinemia in the setting of midline defects and small genitals, it should prompt for evaluation of multiple pituitary hormone deficiency. In such scenarios, a pediatric endocrinology reference is advised. The next step now, when we have a clinical suspicion of either growth hormone deficiency or multiple pituitary hormone deficiency, is to test for the specific hormonal deficiencies. After baseline testing, generally second-line testing with dynamic function tests is undertaken. For example, for growth hormone stimulation, either clonidine or arginine stimulation or insulin tolerance test is performed and the peak growth hormone response is elicited. We generally take a cutoff of 7 nanogram per ml, and a peak response below this is considered as growth hormone deficiency. Most often, 2 tests are necessary to be done. However, if there is one failed test with an evidence of CNS pathology on imaging or clear-cut history of cranial surgery or irradiation, then this is sufficient for the diagnosis of growth hormone deficiency or combined pituitary hormone deficiency. Central hypothyroidism presents with low free T4 or total T4 and T3, along with either a low TSH or an inappropriately normal TSH for the low free T4 levels. Now, cortisol and thyroid deficiencies, when they are central in origin, they are not as prominent as the primary deficiency, and hence stimulation testing in that regard may be important to diagnose them. I'm emphasizing on this again. Low basal cortisol level may not be able to tell us about central cortisol deficiency, and a synacthin or ACTH stimulation test becomes essential to elicit the underlying deficiency. Similarly, the lack of LH and FSH may become evident at a later age, that is pubertal age group, and then a GnRH agonist testing can unmask the deficiencies. So once the specific hormonal deficiency has been identified, the management involves treating the underlying cause, be it infection, tumor, etc., and specific hormone replacement therapy. While replacing, it must be remembered that first hormone to be replaced should be cortisol, following that thyroid and growth hormone. Otherwise, it can lead to unmasking of adrenal crisis. Let us look at a case scenario. We will not go into details, but why I wanted to show this case was to emphasize on growth charting or serial height monitoring. Now, this is a girl who came to us at 8 years and 6 months with poor growth velocity over the last 3 years. Looking at the chart, it is very evident that initially, when she was around 4 to 6 years of age, she was growing along the 50th percentile. Thereafter, she has altered her growth, and in the last 3 years it looks as if she has grown only by 1 to 2 centimeters. So just looking at the growth chart, we can come to know that there is definitely something wrong, and there is underlying growth retardation. If we did not have the previous plots, interpreting just one height would have been a bit difficult. Looking at the weight, we can see that she's following her own weight centile, so weight is fairly preserved. So this might be, or there is more propensity of this to be an endocrine underlying cause. The bone age is marked by the small red triangle, and as you can see, at 8 years, 6 months of chronological age, her bone age is quite delayed, and it is 4 years and 6 months. A Tanner staging showed initial pubertal staging of 2. On evaluation, it turned out that this girl had, on imaging, a lesion suggestive of craniopharyngioma. Now, if you look at the hormonal profile of this child, her free T4 was low, in the setting of a inappropriately normal TSH hormone. Along with this, she has failed 2 GH stimulation tests using clonidine and arginine with peak levels of 2.5 and 1.8. Her ACTH stimulation test was all right, suggesting cortisol sufficiency, and she was having pubertal development as well. So this girl further underwent neurosurgery and was started on hormone replacement, and GnRH agonist was also given to her so as to preserve her final height potential. These children need a long-term follow-up and a regular one, wherein including the clinical parameters, hormonal parameters are assessed, and the doses of the medications are titrated. So now moving on to the second cohort of neurological disorders, which is an interesting one, of CNS tumors. CNS tumors which cause hypopituitarism generally arise in the midline in the hypothalamo-pituitary region, and they constitute to 10 to 15% of all intracranial tumors in children and adolescents. The most common being craniopharyngioma, which contributes to 10% of all the CNS tumors. They can directly cause structural damage, even if they are benign, or functional disturbance to the hypothalamo-pituitary axis. The CNS tumors which are located away from the hypothalamo-pituitary axis can also lead to endocrine disturbances following surgical treatment, irradiation, or chemotherapy. These generally present with the symptoms of the tumor itself, with signs and symptoms of raised intracranial pressure, visual disturbances, certain neurodeficits. They could also be accompanied with symptoms of endocrine dysfunctions related to growth, puberty, salt and water imbalances, etc. Now, this endocrine dysfunction in CNS tumors is generally termed as an evolving endocrinopathy. Many of the symptoms may be present way before the tumor presents itself, and many of them evolve as the child grows. For example, the DI or the diabetes insipidus may be present years before the symptoms of tumor start developing, and the puberty and growth may be affected a few years before or even after the presentation of the tumor symptoms itself. As you can see on the right side, there is a list of other tumors which can be present in the hypothalamo-pituitary region and cause endocrine abnormalities. Moving on to the next set of disorders, which include salt and water imbalance. I mentioned about one which is known as diabetes insipidus, and I'm sure all of us might have come across cases of diabetes insipidus. In simple terms, it is caused because of an increased antidiuretic hormone. Diabetes insipidus lack of antidiuretic hormone. This, as I said, can be present before or post-operatively in children with CNS tumors. Generally, presence of lack of antidiuretic hormone is masked because of cortisol deficiency. And we see that in many cases, once the child is started on cortisol replacement, the symptoms of diabetes insipidus become more evident. This is because cortisol is important for free water clearance through the tubules. Now, this DI, because of lack of antidiuretic hormones, is characterized by polyuria. Parents will often give a history of secondary enuresis, and because of polyuria, there is when the thirst center is intact, the child drinks a lot of water, and there is resultant polydipsia. On lab evaluation, when we do a baseline test early morning, we can often see a constellation of hypernatremia, along with a very concentrated serum with a osmolality of more than 300 milliosmoles per kilo, and a simultaneously low urine osmolarity. So the urine is not concentrated, it is dilute. So we say there is free water loss and hypernatremia in this scenario. Now, this diabetes insipidus in cases of CNS tumors can either be a temporary phenomenon or it could be a permanent phenomenon. And this may require treatment temporarily or for life. Important in the diagnosis is the intake output charting. Sometimes we can explain it to the parents for them to do this at home, or we might need to admit the child in the ward and witness the polyuria ourselves by doing a by doing an intake output charting for 24 hours. Baseline tests such as blood glucose, electrolytes, and paired samples for serum osmolarity and urine osmolarity give away the diagnosis. If the diagnosis is not clear, if you don't get such clear-cut numbers, then a water deprivation test may become necessary in that scenario. These disorders of diabetes insipidus are very tricky to be managed, and they are treated with first treatment of the underlying disease and starting DDAVP, which is available in oral format or sublingual or intranasal or parenteral. The dose of this is not a per kilo dose. It is individualized and arbitrarily. Usually we start at a low dose and gradually titrate the dose depending upon the intake output and the electrolytes. There is one, when these children have a post-operative DI, it is important to know about an entity known as triple phase response as clinicians, because this involves meticulous fluid and electrolyte management. This chart depicts the triple phase response, wherein this phase, that is the antidiuretic interphase, in this phase, we generally discourage starting DDAVP. Otherwise, the risk for hyponatremia and cerebral edema can be very high. The opposite of this is inappropriately high AVP levels, which occur in many CNS disorders as well as pulmonary system diseases in response to cerebral hypoxia or baroreceptor stimulation. Certain drugs are also known to cause SIADH. This is an exact opposite scenario to the lack of antidiuretic hormone. So in this case, we have water retention, free water retention and hypervolemia, along with hyponatremia and inappropriately concentrated urine. There is increased urinary sodium excretion. So these children can also, in case this is a chronic scenario, the children might be asymptomatic and it can be diagnosed on lab parameters. However, if it is an acute scenario, then they can have signs of cerebral edema, raised ICT, and if severe, even seizures and coma. Management of this includes treating the identifiable cause and long-term fluid restriction. Slow correction in both the scenarios are advisable. Otherwise, it can lead to a lot of disturbances and cerebral edema and a risk of central pontine myelinolysis. So we aim at a correction of around 8 to 12 milliequivalents per day, nothing more than that. In some cases, hypertonic saline can be cautiously used. Furosemide with saline, demiclocycline, and Vaptans are other treatment modalities in this scenario. Now, there is another big cohort of disorders which cause neurological disabilities. A large cohort of them do have endocrine problems. The endocrine aspects of disability comprise the ones that we have already looked at. In addition to that, adversely affected bone health, pubertal issues, fertility, sexual function, and contraceptive needs that need to be addressed in these children. A thorough endocrine assessment requires extensive and sensitive history to address general nutrition, specific hypothalamo-pituitary problems, along with parental concerns regarding puberty and contraception. Bone health assessment should include a detailed history about the overall nutrition, calcium intake, vitamin D intake, minimal trauma fracture history, any back and limb pains, and the drugs that the child is taking for the underlying disorder. Challenges in clinical assessment in these children are many. First is it's very difficult to assess the linear growth accurately in these children due to the immobility and due to fixed flexion contractures. And hence, for example, if central precocious puberty occurs in a child with neurological disability, you may not be able to assess the height spurt, or there may not be any height spurt at all. Similarly, masking of symptoms of hypoglycemia in cases with epilepsy. Assessment of polyuria is again difficult as most of them are bedridden or wear nappies. So catheterization may become important in this scenario. So now let us move on to pubertal disturbances. So a lot of pubertal disturbances can occur in neurological disorders, such as central precocious puberty, wherein secondary sexual characters develop before 8 years in girls and before 9 years in boys. Delayed puberty, wherein secondary sexual characters do not develop before 13 years in boys and 14 years in girls, as well as variants of puberty such as premature adrenarche and pubarche. Now, central precocious puberty is, studies have shown that it occurs commonly in children with cerebral palsy. And there is premature adrenarche and pubarche documented in these children due to an excessive DHEAS. This, however, may or may not necessarily progress to central precocious puberty. So as you can see, Tanner staging should be an essential component of clinical examination of children with neurological disturbances. These are the causes that can lead to central precocious puberty, and we have seen that intracranial masses such as hamartoma, astrocytoma, glioma in the cases of neurofibromatosis, HCG secreting germ cell tumors can lead to central precocious puberty. This diagram is just to depict the normal hypothalamo-pituitary gonadal axis, which has these phases. It is essentially inactive during late infancy, childhood, and late prepubertal age group. With the onset of puberty, the hypothalamic GnRH pulse generator is sort of switched on due to opposing increase in excitatory and a simultaneous decrease in the inhibitory signals in the neuronal connections around the hypothalamo-pituitary axis. This results in switching on of the GnRH pulse generator, secretion of LH-FSH, and subsequently gonadal sex hormones. There are other factors which help in the start and progression of puberty. Important among them are certain genetic factors, neurochemical signalings, which I just mentioned, skeletal maturity or the bone age advancement, and nutritional status. The adiposity of the body is an also important factor for the GnRH pulse generator to be switched on, and some drugs. Now, on examination in these children, we can see that the Tanner staging is advanced as compared to their age. So is the bone age advancement. In normal children, as in children who do not have neurological disorders or disability, there is evident height spurt in precocious puberty. However, this is absent in cerebral palsy and severe disability. So on biochemical analysis, we can see that the baseline LH levels in the children with central precocious puberty are elevated. If they are not, if they are borderline, then GnRH agonist testing can reveal LH levels between 3.2 to 5.5 international units per liter, and the estradiol is also elevated. Now, central precocious puberty and in the setting of neurological disability can be a very challenging situation for children as well as caregivers. There can be symptoms such as irritability, restlessness, mood swings, which the parent cannot make any sense of. Also, there is the progression can be a little different from the progression of puberty in normal children. So there may be early onset of thelarche and pubarche, then a period of non-progress, and rapid escalation of pubertal development may be seen. So in such cases, imminent menstruation is a major concern for girl child, especially from the parental perspective. Open discussion with parents about, suppose this child is now nearing the age of puberty, say 8 to 9 years, then allowing the puberty to follow its natural course, telling about this to the parents that puberty is essential, the effect of sex hormone is essential on bone health and bone accrual. However, and it can also augment the emotional maturation in these children, in addition to increased strength of the muscle and helping in locomotion. However, if the child is really young and if the child is really young and having another underlying abnormality of the central nervous system, then treatment with GnRH agonist must be discussed with the parents. Their concerns must be addressed fully as far as for example, the pain and unusual behavioral concerns must also be addressed. Pubertal progression, as we saw, can be intermittent in these children, and parents should be aware that withdrawal bleedings can be something that can be expected. When GnRH therapy is started in such children, the goals of the therapy must be clearly discussed with the parents. As in normal children who do not have an underlying neurological illness, we are not targeting a final height potential or final height improvement. It is more so for the bone age advancement to be halted and the secondary sexual characteristics to be slowed down. In older girls who have started puberty, there should be discussion around OC pills in case menstruation is unmanageable, distressing, or poses hygiene issues for the child. Similarly, there can be pubertal delay because of various central nervous system problems. We know that there are genetic mutations for hypogonadotrophic hypogonadism, and they can be associated with anosmia. Syndromes such as Prader-Willi syndrome, Lawrence-Moon, Bardet-Biedl also are known to cause delayed puberty. Low adiposity, especially in debilitated children who are not fed through a nasogastric or a nasojejunal tube, because of the low fat deposits in the body, can have delayed puberty. Cranial tumors, trauma, inflammatory disorders can all cause delayed puberty. And non-functional pituitary adenomas, space occupying lesions such as craniopharyngiomas or dysgerminomas can also cause pubertal delay. So can irradiation. Now, in this scenario, when we clinically examine them, there will be absence of secondary sexual characters such as thelarchy in a girl beyond 13 years and absence of testicular enlargement in boys beyond 14 years of age. Coexistent midline anomalies also indicate multiple pituitary hormone deficiencies or gonadotrophin deficiency in these children. It must be taken into account that like central precocious puberty, pubertal delay also adversely affects health. More particularly, it adversely affects the bone accrual because of delay of the effect of or influence of sex hormones on bone accrual, and hence increases fracture risk by increasing osteoporosis. The management of pubertal delay now involves treating the underlying cause and pubertal induction using estrogen in girls and testosterone in boys. Neurological disorders and bone health is another important topic. Children with chronic neurological and neuromuscular disorders are vulnerable to poor bone health. We've just discussed that childhood epilepsy, cerebral palsy, Duchenne's muscular dystrophy form a large cohort of children with increased fracture risk due to secondary osteoporosis. They often present with long bone fractures and vertebral fractures. Many of them may not be able to effectively communicate about the pain as well. Osteoporosis clinically manifests as low trauma long bone and vertebral fractures, and hence every attempt to elicit this history must be done. Proactive, timely bone health surveillance and management in this group is advised. Many children with epilepsy are on enzyme-inducing AEDs, which induce vitamin D catabolism, and inactive metabolites of vitamin D are generated. Hence, there is reduced calcium absorption from the intestine, thereby raising alkaline phosphatases and PTH levels, which causes bone resorption. Studies have shown that low bone mineral density in the lumbar spine and femur neck is present, especially in children when they are on AEDs, which induce the hepatic enzymes. Multiple factors that we just discussed result in poor bone health. So in addition to the ones that we have already discussed, low muscle mass, muscle weakness, immobility, reduced exposure to sunlight and poor nutrition, delayed puberty are important factors. This is a slide just to show you the VFA scan and the DEXA scan results. So on the left-hand side, you can see the lateral view of the spine. And at least, I don't know if everybody can appreciate, but the top few thoracic vertebrae, we can see that there is a little bit of compression or a height reduction over here. So when these results are analyzed, there is a Ganant scoring, which can tell the percentage reduction in each vertebral height and tell us whether there are fractures in the vertebrae present or not. Now, the advantage of DEXA scan is the radiation exposure in DEXA is much less compared to radiographic studies. So nowadays, children who are debilitated, who have an evidence or who have a risk factor for osteoporosis are proactively screened with DEXA scan and VFA scan to assess the bone health and underlying fracture risk. On the right-hand side, you can see the results for lumbar bone mineral density, which is graphically represented, and the blue and the yellow zone is the acceptable zone. So this child does have a bone mineral density within -2 and +2 standard deviation, as shown by the small black dot. The lower figure shows the total body less head bone mineral density, which looks to be normal as well. So this is a very good tool to assess the risk for fracture and osteoporosis. Now, Leanne M. Ward, I came across this very elegant paper by Dr. Leanne M. Ward, which outlines 4 phases of management of children with Duchenne's muscular dystrophy, addressing to their bone health. The first phase is about proactive monitoring. As I said, annual bone mineral density by DEXA scan and VFA scans are undertaken. In addition to this, a detailed history about the bone health, which involves bone pain, back pain, any fracture induced by low trauma, a detailed history about intake of calcium and vitamin D medications. Vitamin D levels are tested in these children at least annually. And if the bone mineral density or scan is not available, at least 2 yearly lateral spine radiograph to look for any vertebral fractures is important part of monitoring for bone health. For those who have been identified with clinically significant fractures, by which we mean low trauma fracture of the long bones or any single vertebral fracture. In such cases, IV bisphosphonate therapy is now the first line treatment, which is started in these children. And the aim is to stabilize the vertebral fracture, ensuring that there is safety and efficacy of the treatment, all the while maintaining calcium and vitamin D up to the mark and monitoring for renal parameters. In children with Duchenne's muscular dystrophy or other muscular disorders, physical therapy, weight-bearing exercises, adequate nutrition causes a lot of impact on the positive impact on the bone health. Even after the stabilization of fractures, it is important to maintain the IV bisphosphonate therapy. This may be titrated and the doses may be reduced towards the lower normal end, or the duration of the therapy might be increased. For example, if the patient was initially taking 6 monthly, then the therapy can be made 9 monthly instead, depending upon the child's pubertal status and ongoing steroid treatment. The aim of this is to preserve the gains that we have attained in stabilization phase, and also for the vertebral body to be reshaped, as that occurs only during the growth phase. Once growth is completed, vertebral body reshaping cannot occur. And then discussion around stopping or discontinuing the osteoporosis therapy of IV bisphosphonates. This is generally done when final height is attained and when we have witnessed stabilization of the vertebral fractures or bone health. In case after 18 years of age, there is again worsening disease, then reinitiating the IV bisphosphonates can be considered. So as I said, the aim of the therapy should be clinical stability, wherein there is absence of non-vertebral fractures, stable healed vertebral fractures, absence of any new vertebral fractures in previously normal bodies, absence of bone and back pain, and a normal bone mineral density Z-score. We aim for vitamin D levels preferably above 75 nanomoles per liter. Optimization of calcium intake and a balanced nutrition along with physical therapy has a positive impact on bone health, and so does timely exposure to pubertal hormones. Moving on to neurometabolic disorders, which can have adrenal involvement. Very briefly going through adrenal hormone excess, which can occur in ACTH secreting pituitary adenomas. This is a very, very rare scenario, 2 to 3 cases per million per year. With that, only 10 to 20% of them occurring in childhood. So generally, these children who have Cushing's disease, they present with weight gain or obesity, a Cushingoid habitus, moon phases, and ACTH excess signs such as hyperpigmentation, catabolic signs of stria, easy bruising, and proximal muscle weakness, and effect of steroid excess on the bones, causing secondary osteoporosis. They also have hypertension on examination, and lab can reveal hypokalemia in some cases. So again, the management is treating the underlying pituitary adenoma, and mostly it is surgical. Once the pituitary adenoma is treated, these children, some of them may need to be on hormone replacement therapy later on. Other set of disorders such as causing adrenal insufficiency are adrenoleukodystrophy, wherein this is caused by X-linked peroxisomal disorder, and it is caused by impaired fatty acid metabolism and accumulation of very long chain fatty acids in the central nervous system and the adrenal glands. So the prognosis of this is not very good, and it causes death in a few years of diagnosis. Children present around 8 to 10 years of age with features of demyelinating encephalopathy, such as dementia, blindness, deafness, quadriparesis, and even seizures, along with primary adrenal insufficiency. So in case there is an intercurrent illness, they may come with adrenal crisis, and there is evidence of increased ACTH by hyperpigmentation evident on clinical evaluation. There are lots of other syndromes which have neurological features as well as adrenal affection in common, such as Zellweger's image, Smith-Lemli-Opitz, and the quadruple A syndrome. A variety of medications can also result in endocrine dysfunction. We have discussed a few of them previously, but just going through them in brief. Now, medications which can affect the thyroid function, wherein the hypothalamo-pituitary thyroid axis is intact, such as those causing TSH suppression, namely glucocorticoids, or dopamine agonists or bromocriptine, which can be used for treatment of hyperprolactinemia, somatostatin analogs, and carbamazepine or oxcarbamazepine. Then there are medications which affect the thyroid functions in patients who are already on levothyroxine treatment. So these can have implications in their dose adjustment and maintaining normal TSH and free T4 levels. These are the medicines which cause increased hepatic metabolism by inducing the cytochrome P450 enzymes, such as phenytoin, phenobarbital, oxcarbamazepine and carbamazepine, and valproic acid. So in case in case these medications cause derangement of thyroid function, and in spite of adjusting the dose of thyroid, you're not able to maintain the normal levels, consideration to newer anti-epileptic agents might be the next line in this regard. Also, glucocorticoids cause decreased thyroxine binding globulins, which can result in lab errors. Bone health is also adversely affected, like we saw, by enzyme-inducing anti-epileptic drugs, as well as by glucocorticoids. So to summarize, children with neurological disorders are more predisposed to certain endocrine conditions, as we saw. Monitoring these children through a detailed history, anthropometry, Tanner staging, clinical evaluation can lead to an early diagnosis of an endocrinopathy. CNS disease can affect the hypothalamo-pituitary target organ axis and lead to both anterior and posterior pituitary hormone deficiencies. Neurodevelopmental disorders also have an increased risk of poor bone health and may cause secondary osteoporosis, especially if there is coexistent epilepsy. In this regard, bisphosphonate therapy is now the first-line therapy and is known to decrease the fracture frequency. So knowing about these endocrinopathies, and being aware of them can help us anticipate them, proactively screen for these hormonal disturbances, and treat them to ensure better outcomes and decrease the debility. These are my references. Thank you. I hope I haven't exceeded the time too much.
No, thank you very much, Dr. Madura, for that very brilliant presentation. So if there are any questions, please type them in the Q&A chat so that we can go through them. You've raised some very important issues. I think one of the major challenges we have in patients with neurological disorders is puberty. Not only just normal puberty, but those who have precocious puberty. Often you'll find parents coming in and asking if there's any medication that you can use to stop the menses for these children, because they fear many challenges such as pregnancy or sexual abuse in these children. So how do you usually have conversations around this challenges for those pubertal patients who have neurological disorders and are unable to, to speak out on what they would wish to have?
Yeah, it is very important to openly discuss with them and first listen to their concerns, as in many of the parents may be concerned or fearful about the impending menarche, as I said. Some may be having difficulty in dealing with hygiene. Others might be more worried about the sexual exposure and pregnancy, etc. So I think a detailed discussion with them and addressal of each and every issue one by one is very important. At the same time, this is something that normally occurs in children. So unless there is necessity for halting the pubertal progress, like I said, in very young children or children who are having another secondary pathology, if the puberty is occurring at, say, near the age of maturity, there should be an open discussion with them about the positive effects of puberty as well. This may require more than one time consultation. It may require involving the other members of the team as well. However, allaying their anxiety, wherever necessary, starting the GnRH agonist therapy, wherever necessary, supporting them when they are having challenges managing menstruation, giving them an option of OC pills, etc., should be openly discussed, and accordingly the treatment should be individualized. It may not be a one solution fit all, but it can be a collective decision about what suits the parents best and what is in the best interest of that child.
Thank you very much. You also discussed bone health and you mentioned annual vitamin D, calcium, as well as bone densitometry. Is bone
Yes.
densitometry available in Kenya, and what are the cost implications? And how often would you suggest it be done in our setting where it may not be readily available to the public?
Yeah.
And
Yeah.
in addition to that, you also mentioned the use of IV bisphosphonates in patients who have a low Z score.
Mm.
So how
Yeah.
practical is it to give IV bisphosphonates in our setting? And is there
Mhm.
a role for the oral medications like alendronate or risidronic acid?
Okay, thank you. They're really very good questions. Firstly, a bone mineral densitometry and DEXA scan is available, as far as I know, at least in 3 or 4 big institutes in Nairobi. One is very near to where I practice, so Aga Khan Hospital does it, and one is a private radiology center, and I'm sure it is also available in the university hospital. The cost implications, I really won't be able to answer that very well. But I feel that wherein something is preventable, where we know that there is a risk of secondary osteoporosis, if we are able to do the bone mineral density scan and document it, we can start the treatment with bisphosphonates early. And your third question was about bisphosphonates versus oral
IV
medications.
bisphosphonates.
So
Yes, yeah.
oral medication. Yes, IV bisphosphonates. Now there are two that are available, pamidronate as well as zoledronate. I have had experience of using both of them. However, in the UK, zoledronate was the norm because it is given at a longer interval and it has lesser renal side effects, and it has had better results with reducing the fracture rates, definitely when compared to the oral counterparts. So especially vertebral bone mineral density improvement has seen to be more with IV medication as compared to the oral medication. Plus the oral medications can be, there can be absorption issues, etc. So I feel giving IV zoledronate, let me share with you my experience. It used to be a outpatient procedure for all the Duchenne's muscular dystrophy children. So we had segregated the cohort, and they underwent annual bone mineral density assessment or vertebral fracture analysis with the help of a lateral X-ray of the spine. If that is not feasible, at least looking at a lateral spine radiograph, keeping in mind the propensity of these children for vertebral fractures, should be undertaken once in 2 years. But wherever possible, because this is a long-term illness and the radiation exposure can be a lot, which is reduced with the use of DEXA scan, so that should be aimed for. And since it's a zoledronate is usually given like a daycare procedure, maybe the first injection can require an admission to look for the first phase reaction, fever, etc. But subsequently, it can be easily managed in a daycare wherein the child comes, has his injections, is there in the daycare clinic for a couple of hours, and is discharged on the same day. And this injection is usually given once in 6 months. So in the end, if you see the fracture prevention, the prevention of hospitalization, the improvement in mobility, all that ends up cutting the cost if you are to weigh the cost benefit ratio. So I would suggest, wherein possible, it should be done. These osteoporosis should be assessed, and the treatment should be started early. That's the only window we have. The vertebral remodeling can be done only till the growth is completed. There's no point doing it afterwards.
Thank you.
I hope I have
There's a
answered.
question. Yes, I think it's very clear. There's a question that asks on some light on the management of stress-induced hyperglycemia. For example, if you have a newborn with meningitis who's very sick with persistently high sugars that are unrecordably high. So how would you manage this?
So in my experience, if there is a stress-related hyperglycemia and we are treating the underlying cause, usually within 48 to 72 hours, the hyperglycemia resolves. If it is requiring more than that, then insulin therapy may be required in such children. But in my experience, it has been rare. Children who remain hyperglycemic beyond 72 hours in spite of tackling the underlying infection or cause you may have to consider then other causes of hyperglycemia such as neonatal diabetes. But usually if you're treating for the infection with sensitive whatever antibiotics, then the hyperglycemia should slowly respond. One or two insulin doses may be required, but it should subside unless there's another underlying cause.
Okay, thank you. There is another question that asks, patients on levothyroxine, 100 micrograms for 2 months, and a repeat TFT, TSH is very high as the previous result of 100. So how do you manage this?
More like, I think this girl, this child has primary hypothyroidism by the looks of it. And so for the dosing, many factors can be underlying. The weight of the child, maybe the 100 micrograms is not enough. I hope the cause is clear in this scenario, that it is an autoimmune thyroiditis, which is most common. So titrating up the dose, look at the compliance. Many children say they are taking, but they generally don't take. So it will be a good idea to ask them to bring the thyroid bottle, the thyroxine bottle, and check the compliance. Check if the child is taking any other medications like we just discussed, and if that is causing the medication to metabolize. But I would say look at the compliance, because 2 weeks there should be some increase in the free T4. TSH may take a little while to come down, but definitely the free T4 should improve by now.
Thank you for that. I think that's very clear. Another question is, can we do annual bone-specific alkaline phosphatase and PTH to monitor the need to initiate calcium and calcitriol in MBD, which I think is metabolic bone disease?
Okay, so bone-specific alkaline phosphatase is, and I don't know how many centers do it here. Generally, we do calcium profile and alkaline phosphatase, and the cause of the underlying metabolic bone disease needs to be looked at, whether it's vitamin D deficiency, or is it vitamin D metabolism problem, or is it resistance to vitamin D. So get to the cause of the metabolic bone disease in this case. It could also be low phosphate levels, increased urinary excretion, and hypophosphatemia in that regard. So first get to know what the cause of metabolic bone disease in this scenario is. And depending upon that, calcitriol can be started. So it'll entirely depend on what the underlying cause is actually. If it is just a vitamin D deficiency, then there is no need to start the active vitamin D. Your cholecalciferol and calcium supplements can take care of that. However, if it is a more severe disorder affecting vitamin D metabolism, that is the case when you may need to think about starting alpha calcidol and calcium. So first get to the bottom of what the cause of the metabolic bone problem in this case is.
Okay. And then another question is, do you have an actual age cutoff for bisphosphonate supplementation?
Uh, so we have used bisphosphonate, specifically zoledronate, in very young children as well, even in infancy. So we used to get cases of children who had neonates who had fractures soon after birth. So in the initial 2 years, generally we say pamidronate is better to be used because we have more experience with that. And after 2 years of age, you can start zoledronate treatment. So there are specific protocols or age-related doses, but yes, it can be given to children as young as, early infancy or even in neonates to prevent further fractures.
Okay, thank you for this. There are lots of questions on whether this webinar will be available. Yes, it will be posted online on the KNH website. And for those asking about CPD points, they'll be loaded automatically on the KMPD website. Another question is, can I think this is SIADH occur in TB meningitis?
Yes, I mean, you really cannot, point out if you are having a scenario, clinical scenario, wherein there is those clinical symptoms and lab results suggesting of SIADH, and you have an underlying setting for TB meningitis, and you've proven it on your test, it can definitely be a cause. CNS infections can cause SIADH, yes.
Okay, thank you. And then there's a question that's being asked, at what point should a child be given a vitamin D injection? I think this is a bit broad, but maybe you can answer it for us.
No, it is fine. Actually, there is such varied treatment of vitamin D deficiency. So, vitamin D sachet oral supplements of cholecalciferol are quite equally effective. And unless their absorption is an issue or the compliance is a major problem, injectable vitamin D may or may not be considered. So because the oral preparations are quite well absorbed. So if you can ensure compliance with the oral medications, then giving the oral treatment for its duration is as equally effective. And you may not require to give the injection.
Okay, thank you. I think this other question you answered, it's if a child has been on levothyroxine for 2 months and still TSH is high, but T3 and T4 are okay, do you continue with the same dose or will you need reducing?
Okay, now if the free T4 has normalized, you can give some time for the TSH to come down. TSH may take 2 to even 4 weeks to come down to normal. So if you're seeing that the free T3, free T4 have come down nicely, then and the child is improving in terms of symptoms such as edema, etc., you can still wait. However, then you need to ensure that you have a follow-up after 2 weeks to check what is happening.
Thank you very much. Lots of questions concerning the CPD points. I think we can address them
Okay.
to the KNH email.
Yeah.
Otherwise, thank you. I think there are no more questions. So thank you very much, Dr. Madhura Joshi, for that very brilliant presentation. I think
Lucia,
we've learned a
I have a
lot.
question
And
for you. Can I ask you?
yes, sure, Dr. Madhura.
Yeah. So I was just curious. I wanted to know, currently, are we practicing bone health assessment by way of doing a densitometry in our centers in Kenya or Africa?
So I think for bone health in Kenya, what we mainly do in our setting, especially in the public setting, is just the vitamin D and the calcium levels. Unfortunately, bone densitometry is not yet widely available for the majority of Kenyans. As you mentioned, it's only available in a few centers, but we are hoping this is something that with time can gain traction and be more
Mm.
readily available for Kenyans to utilize. Because as you've said, it's something very useful in detecting low bone density in pediatric patients. So it's something that has not yet gained traction, but we hope that it will in the future.
Thank you.
All right. I think we will end our presentation here. Thank you, everyone who has tuned in. So next week, we'll have a very interesting topic. We'll be looking at pediatric headaches. So please tune in as we continue this pediatric neurology series. Dr. Madura, do you have any parting shots before we end the webinar?
No. Thank you. Thanks so much. Thank you, everybody, for participating. And thanks, KNH and Lucia, for giving me the opportunity. And as well, thank you to all the PESC members for being a real encouragement.
Thank you very much. Lots of congratulatory messages. Good night, everyone. We'll see you next week.
Yeah. Good night. Bye-bye.